Hello everyone, Dr. Akshaykumar Kamble here, consultant neuroradiologist. I'll be taking another mock exam today. So this patient presented with a chronic cough. This is the scan.
I'm given a frontal chest radiograph of an young adult. I noticed there is opacity projected over the left upper zone with obtuse angle with the lateral chest wall, probably of extrapulmonary location. There are also areas of reticulonodular shadows with apical preponderance. There's also, I would like to evaluate the hilum. The right hilum is not enlarged to me, but the left hilum is slightly obscure and demonstrates upward elevation. I would like to scrutinize the film for any pneumothorax which I do not see. There's pleural thickening over the left lung apice, and also a blunt left costophrenic angle suggestive of a small pleural effusion. The heart size is not enlarged. There's no destructive bone lesion. Constellation of findings would suggest a diffuse process of the lung. If this patient is acutely unwell, I'm concerned about atypical infections such as tuberculosis.
What would you do the next?
I would like to advise the referral to infectious disease unit and for microbiological and clinical correlation, and advise for isolation if it comes back as tuberculosis, and also screening for the co-inhabitant.
Okay. I'm scrolling for you.
Yeah, I'm given a contrast CT thorax in soft tissue window. I noticed there's a cavitary lesion with perilesional enhancement over the apical left upper lobe with cavitary changes and internal cystic changes. I would like to scrutinize the film to see if there's any dilatation of the pulmonary artery or vein in vicinity.
Why is that important?
Because in the case of suspected tuberculosis, it could be complicated with Rasmussen aneurysm, and that would lead to torrential bleeding. I would like to see if there's any enlarged lymph nodes.
Do you see some here?
I think there's some at the there's some prominent lymph node at the aortopulmonary window. Okay. I would like to evaluate the images further by
the. Is this?
This is at the subcarinal region. Okay. I would like to evaluate in the lung window.
Yes.
There are clusters of centrilobular micronodules at the left lung apices. which appears to be in a tree in bud configuration, is
Okay.
suggestive of an endobronchial process. Overall findings are in keeping with a infective process that is suggestive of tuberculosis in this clinical context. So I would like to inform the referring clinician urgently and
Mm-hmm.
advise for further infectious disease opinion in form of microbiological investigation as well as medical treatment.
Okay. How do they treat TB? Do you know?
DOT, direct observed therapy, it depends on whether it's an open or closed TB. So
Mm-hmm.
if it's open TB, the patient should be isolated
Mm-hmm.
and with serial sputum tests. And then after a series such as three negative tests, the patient should be allowed returning into the community and for
Mm-hmm.
direct observed therapy for a duration of at least 6 months.
Okay. Good. Patient presented with a headache. You can start with by telling what sequence it is.
This should be in coronal flare.
Mm-hmm.
I'm given the coronal flare images of the brain. There's an extraocular lesion at the left frontal skull fault with heterogeneous flare hyperintensity exhibiting mass effect with effacement of the cell side as well as obliteration of the left lateral ventricle. Um, in my practice, I evaluate midline shift in SU images, but I still suspect there's a mild midline shift in this coronal image. This is a
That's just a T2, yeah.
T or T2 images. It appears to be largely T2 hyperintense with areas of serpiginous T2 hypointensity, giving rise to a flow void. So I suspect there's some peripheral vascularity associated with the lesion.
You're talking about these things.
Yes.
What else it could be?
It could also be part of the eroded skull fault.
Mm. So, would you like to comment on the skull? That's a T1 to make it easier for you to comment on that.
There's also loss of normal fatty marrow signal over the skull fault with a almost like a bevel edge appearance.
Mm-hmm.
I suspect that this lesion may represent element. This could represent a frank deposit of Langerhans cell histiocytosis
Mm-hmm.
with differential consideration of skull metastasis or a less likely atypical meningioma, such as those hemangiopericytoma. I would like to take this case further by urgently informing the referring clinician about the findings and advice for further systemic imaging.
They are asking, can they biopsy it? If it's so superficial, should they directly go for biopsy?
Um, I think I it's accessible for biopsy, but I would advise neurosurgical opinion before contemplating
No, no, no.
biopsy.
Neurosurgeons in MDT, you present it in MDT. They're asking you if you're thinking in the line of tumor, should we biopsy it?
Uh, I think there are other imaging modalities such as the nuclear imaging that may be helpful, like the MRPG scan
It,
that may forego the need for biopsy.
it will show high uptake, then what you will do in the nuclear?
Uh, True.
Because any extraaxial lesion, it's always hyper in the. But that is a good finding that you caught it that it's extraaxial. Why you thought it's extraaxial?
Well, actually, it's better to be evaluated on the T2 images to look for the, I mean, the thin CSF cleft, which is a
Do you
bit
see any
high.
CSF cleft? Do you still think it's extraaxial?
Okay. Well, I don't really see a CSF cleft here,
Mm-hmm.
but the adjacent brain
Mm.
parenchyma is so compressed by this
Yeah.
lesion.
What is that sign called? Cortex buckling
What do you
sign.
call?
That's called cortex buckling sign.
Okay.
So the cortex is buckled. So even though if you don't have that, you're right. That's extraaxial. I don't want to confuse you anymore.
Okay.
And also you need to look at vessels as well. You see these vessels on flare. They are away
Oh,
from the lesion, which are in the brain. You see these spiral vessels that are displaced inside. Yeah.
okay.
Let me zoom in to show you. Yeah. Yeah. So the case is over now. I'm giving you feedback. So you're right. This is extraaxial lesion. Intensity wise, this is how you will say on flare.
Mm, flare kind of flare hyper intense
Hyper intense. But what about these things?
with this central
Yeah.
hypo intensity.
Yeah. So you will call it heterogeneous, won't you? You won't.
Yeah.
You won't label it directly. Why you did not ask me the T1, even though I showed you T1? What's the intensity on T1?
It's again a bit heterogeneous, but mostly
Yes.
hypo
Hypo.
intense.
Okay. How is it on T2?
Hyper.
Hyper.
Yes, hyper
So
intense.
how many meningiomas and um, Langerhans cell histocytosis, which are hyper. Usually they are hypo. Yeah.
Yeah.
Unless the like very rare meningiomas, which are like microcystic meningiomas, they will be hyper. Hemangiopericytoma, I agree, would be hyper, but it will have lot of flow voids, isn't it,
Okay.
inside?
Yeah.
Because it's very, very vascular. So you picked up these things right, that these are hypo intense, but that's why I was giving you T1 um,
Mm,
images. That's a part of bone. So if I would describe it, I will call it scalloping the bone because
scale. Okay.
it's not really going and destroying it. And so this was done like long back, 10-20 years back. So that time they did not used to do diffusion. So if I show you that tell you that this lesion is showing intense diffusion restriction, would it change your differential?
Oh, it could represent epidermolysis.
Yes. So it's a rare entity of intradiploic epidermoid cyst. So I don't expect you to get the answer to this. So sometimes you can get some cases which would be too difficult to get answered. So that examiner will look at your approach to the case. Yeah, not necessarily the diagnosis. It will be a difficult case. No one will get the diagnosis. It might be a rare case or it might be a simple case like epidermoid cyst, but will in an unusual area. Usually you have it in CP angles. Yeah, but your approach should be important. Like you look at T1, you look at T2, and then you tell them that okay, I'm thinking about meningioma, but most meningiomas are hypointense. I'm thinking about hemangioparasitoma, but I'm not seeing the flow void. So I'm ruling out all those things, but I'm considering all the extraaxial things, and then I will refer it to MDT, and then they can do biopsy or whatever they want.
Okay.
So yeah, so because cases like this, usually you make a diagnosis retrospectively, unless you have some sequence like diffusion and things like that. We do it very routinely, isn't it? Diffusion and everything. But there was a time when we didn't used to do that. So so yeah, you all of you did well. And the previous case, the TB case, you hit it out of the park. It was really good. You caught it on X-ray that it is diffuse. It's showing some areas of fibrosis, necrosis, and it was good. You could have also commented on there are some lymph nodes which are caseating because
Okay.
it was a contrast enhanced scan. Usually, lymph node should show enhancement, but
Mm.
they were not showing that. So you could have told that they're showing central necrosis caseation. But yeah, all of you have done a good job. Do you guys have any questions? How was it? How was your feedback about the session? Did you find the cases too hard, too
Yeah.
simple?
Yes.
Yeah, we like to see more
Yeah, of
X-ray,
Yes.
yes.
especially
X-rays.
MRI. Not very familiarized with the sequence. I'm not very familiarized with the MRI sequence.
So what would you like to see more? Like more X-rays or more MR, or what would you what is the thing in future if you organize it again? Did you find the case selection in this session was okay, or you find it skewed towards one specialty, or what was your feedback about it?
Very nice.
Yeah.
Yeah, they are good capacity.
And you choose from different levels of difficulties.
Yeah. So I tried to give you guys one radiograph and one cross section, because in exam it usually would be something of mix. And so because they want to see that you are all rounder, that you are hitting all those areas. So it might be in your routine practice you are good in one and not that much in other, but what they're trying to assess is your safe radiologist. So you're not saying something benign as malignant. So that's why description is really important. Like the terms like it's scalloping, or if it's a bone tumor, you need to say whether, well, how is the transition zone. If it's a breast cancer, you need to say what is the architecture around it.